We are live.
Good evening, everyone. Myself, Dr. Praful, and today we have another lecture of DOS-PEP on another important topic. We all know STRABISMUS neuro-ophthalmology troubles us a lot. That's why we have created this module, and we have increased the number of lectures so that you get enough time to understand the basics of the topics. And as I had promised you all, we'll save the PDF of all these PPTs once the module is over. Okay, so with this, I'll say thank you to Dr. Deepti for agreeing to take this lecture. And I'll request Dr. Pranita Sai to introduce our speaker and start the session.
Thank you, sir. So, sir, as sir has already introduced, that Dr. Deepti Joshi ma'am will be taking the class on binocular vision and tests of binocular. Today, we are on the 4th lecture of Strabismus module and on the 49th lecture of our DOS-PEP. Our moderator for the session is going to be Dr. Gunjan Saluja, who's been there with us since the beginning of the Strabismus and NEURO-OPHTHALMOLOGY module, and Dr. Anita Gangar will also be with us, who's a senior consultant at Gangaram Hospital. Dr. Deepti Joshi, the speaker for the day, is a pediatric ophthalmologist at the M.M. Joshi Eye Institute in Hubli. She is actively involved in PG teaching for the past 10 years and has been the recipient of Best Squint and Trauma Paper Award at AIOS, Best Squint Video at the World Society of Pediatric Ophthalmology and Strabismus, and various other conferences. She has received multiple awards in the field of strabismus and pediatric ophthalmology. She has multiple publications to her credit, and beyond ophthalmology, she is also enrolled in Limca Book of World Records for training maximum number of teachers at a stretch about safeguarding children against child sexual abuse, and has something to her credit, to her name, beyond ophthalmology, doing something for the social causes as well. So with that, I'll hand over the dais to Deepti ma'am for her talk today.
Thank you, Dr. Praful and Dr. Pranita, for that wonderful opportunity and the introduction. So without wasting much time, is my slide visible?
Yes, ma'am, it's visible.
Yes. So postgraduates, here is a man who has been looking at an ant. So let's not directly jump into the topic. Let's just make it a bit interesting, because BSV is a very dry topic, requires a lot of involvement to understand this. So this is a man who has been looking at an ant, and now with his one eye closed, if he closes his right eye, with the left eye he will be looking at a single ant. Now when he closes his left eye, with the right eye he will look at a single ant. But then when he opens both eyes, instead of seeing two ants with both eyes, he would actually end up seeing one single ant, as though he's been having a cyclopean eye. So this is what we are going to talk about today, and that's our topic. That is, despite having two eyes, we don't see any subject as two, and we end up seeing all the objects as single, and that is our binocular single vision. And so coming to the definition, binocular single vision is basically your ability to use both eyes simultaneously to achieve single vision in a fused form, single fused image, and in the presence of disparity despite being seen with each eye. So if you look at a ball, if you keep a ball in front of your eyes, from the left eye you would be seeing the left half of the ball, from the right eye you would be seeing the right half of the ball. Despite that, when you see with your both eyes, you see a single round ball, and that is despite the disparity between the right and the left eye, we still end up fusing it and producing one single complete image, and that is what is the definition of binocular single vision. So to have a binocular single vision, you need to have no manifest squint, you need to have sensory and motor fusion, and an equal image clarity from both eyes. And that's the reason, if the image clarity of one eye gets hampered either due to cataracts or due to anisometropia, people usually complain to us of diplopia, because the binocular single vision gets hampered in those situations. So why do we have this? Why should we be reading this? What is the advantage of binocular single vision? The name itself suggests the most important and the single most biggest advantage of binocular single vision is the single image. So despite, that's what I said, despite having two eyes and the different disparity of an object, we see one single image, and that is the advantage. The second one is stereopsis. So for example, look here, there is a man and behind him there is a tree. But when you look with your left eye, you would actually end up seeing the tree to be on the left aspect of the man. When you see with your right eye, you would see the tree on the right aspect of the man. This is individual eye image. But when you see with both eyes, that is when your brain fuses and tells you that neither the tree is on the left nor the tree is on the right. It's basically behind the man in a 3D space. And this is actually the stereopsis, which is an advantage of the binocular single vision. The third advantage of binocular single vision is visual field. So if you see here, there is an orange circle. This orange circle is the field of your left eye, and the black circle, which is the field of your right eye. But when you see with both eyes, this
So then, if there are some issues,
I think that we have lost ma'am's connectivity. I'll just check with her.
Sunil, are we live or what? If there is anyone from admin,
I'm just logging in. I'm logging in.
Ma'am is logging in. She just got logged out, sir. We are live. Ma'am is connecting back.
it's okay, but there should be some admin support, right? Both of them are, I think, gone. In the meanwhile, to all the students who have logged in, our winter DOS is going to be held between 11 and 12 October. So the abstract submission was closed yesterday evening, today evening rather, in fact. So if by chance you could not submit, you have missed, you can send me directly. I'll include in the program. Okay, so we are back to the class. Yes, Dipti, continue.
Yes, so I'm extremely sorry. So with this now, with totally, when you use the whole eye, you can actually use both the image together. So your field of vision increases, and that in turn, because of the increased field of vision, we are also compensating on our blind spot. So this is what are the advantages of the binocular single vision. Now there are few milestones which you need to remember, like at 2 months, there is a bifoveal fixation. At 4 months, there is a sensory fusion. 5 years is the stereopsis, which is completely developed. So these are just to be biated, to be known, and milestones of the binocular single vision. Now, before we go into complete binocular single vision per se, there are certain terminologies that you need to know. So for example, the first terminology that you need to know would be the retinal correspondence. So what exactly is retinal correspondence? So if I have to see, look in the image, if I have to see the image object X, then this object X is seen by the fovea of the left eye and the fovea of the right eye. So that means the fovea of the left eye is directed towards the object X. The fovea of the right eye is also directed towards the object X. So both of them have got a common visual direction. So that means they are corresponding retinal elements. Similarly, if I want to see the object Y, nasal part of the retina of the left eye, temporal part of the retina of the right eye will have the same visual direction. And if I have to see the object Z, then temporal of the retina left eye and the nasal part of the retina of the right eye. So that means in a case of normal retinal correspondence, fovea of two eyes have the same visual direction. Nasal retina of the left eye and the temporal retina of the right eye have same direction, and temporal retina of the right eye and nasal retina of the left eye have the same direction. These are known as normal retinal corresponding points, and a person whose eyes are working in this well coordinated way is said to have a normal retinal correspondence. Now, If there is something normal, then there should be something abnormal too. So what is abnormal retinal correspondence? So consider a patient has a small angle squint. So what is happening here? This patient has a small right esotropia. Now the fovea of on the nasal part of the retina, which is P, is looking at the object O. So the fovea of left eye is starting to work with a non-foveal point of the right eye to prevent diplopia, because the angle of squint is very small, and so it thought chalo fovea nahi, fovea ke बाजू के जगह से adjust कर लेता हूँ, and this is to create a binocular single vision despite a small manifest squint to prevent any problem to your eyes. This is known as abnormal retinal correspondence. That means a fovea of one eye and a non-foveal point of the other eye starts behaving like corresponding points. That means enemy starts behaving like a friend. This is your abnormal retinal correspondence. So now that you know what is corresponding points of the retina, we need to learn another point which is known as a horopter. So horopter basically means horizon of vision. So if all the retinal corresponding points are joined with each other, so object 1 is corresponding to retinal, some corresponding retinal points, 2, 3. So all of them, when you join all the loci of points which project on the corresponding retinal points, this will give you what is known as a horopter. And this horopter, initially Muller thought that is a circle which passes through the center of the eye. So it was known as a Muller's circle horopter, geometrical horopter. But now we know that it is no more circular. It is basically, look at that orange line. It is basically more flatter, more elliptical, and this is known as the empirical horopter. So this is how the actual horopter is, not a circle, but a more flat elliptical. This is known as the empirical horopter, and this is what is accepted nowadays. So the difference between this Muller's horopter, that is the green one, and the empirical horopter, that is the orange one, this different area is known as Herring-Hillebrand deviation. Doesn't make much for your practical purpose, but for theory, BSV has always been asked as one of the question. You should draw this image. Horopter is a 100% question in your exam. So you should know green is Muller's horopter, orange is the empirical horopter, and the difference between those two is your Herring-Hillebrand deviation. So now that we know what is horopter, so what do we mean by horopter? We told that on the horopter, whatever object is there, it projects on the corresponding retinal element. So if an object is on the horopter, like this object, this object, this object, all of them are on the horopter. All are being projected on the corresponding retinal points. So we should not see anything as double. That means we get a binocular single vision. Does that mean anything which is outside the horopter will give us diplopia? No. There are few points, some amount of area above and below the horopter. This much area also, if the object is present, we will not have diplopia. Anything beyond this purple zone will give you diplopia and disparity. So what is this purple zone? This purple zone, which is around the horopter, is known as Panam's fusional area. So anything in the Panam's fusional area will also not give you diplopia. That is because your fusion is acting over there. So what is fusion? So for the fusion, so when we come to fusion, there is basically two types of fusion. One is sensory fusion, one is motor fusion. So what is sensory fusion? Sensory fusion happens in your brain. Motor fusion happens in your eyes. So whenever there is any object which gets stimulated on the corresponding retinal point, each retinal point has one corresponding point in your brain also. So whenever any corresponding retinal point is stimulated, corresponding areas in the brain get stimulated, and that brain will fuse all the images and give you one single image, and that is sensory fusion. Motor fusion is nothing but when the muscles of your eyes act together. So if I want to see this pen, now my medial rectus of both eyes will act together, converge the eyes, bring my eyes on the focus on the pen, and that will prevent diplopia. So this motor activity which is happening inside my eyes is basically motor fusion. So because of these two fusion, both my eyes, both part of my brain, my visual cortex all act together, and that prevents a diplopia which happens in the Panem's fusional area. So this, for example, now look at that butterfly. So to look at this butterfly, this eye had to rotate slightly inwards to bring this butterfly to come on the focus. See, now the eye came out to bring the butterfly on the focus. So this movement of the eye causes the corresponding retinal points to come on focus on the eyes, and because of this, impulses go to the brain, sensory fusion will happen, and you will have a stereopsis. So first motor fusion happens in the eyes. Your both muscles will act, your eyes will act together and see two objects. Then these impulses go to the brain, and all the brain particles act together, sensory fusion happens, and finally you get a stereopsis. This is what is happening. These are some normal fusional amplitude. This is just for your information. So the fusional amplitude for convergence and divergence, as well as vertical fusion for both distance and near. So you can just by at them. That would be sometimes asked in your exams. So now, in case the fusion doesn't happen, okay, and you start having diplopia, or you are both the eyes are not acting together, then what to do? Then the eyes have some sensory adaptations to bring a comfortable single monocular vision or an anomalous binocular vision, so that you don't have either diplopia or confusion. These are few of our sensory adaptations. So sensory, to know what is sensory adaptation, you need to know whether we are talking about a visually mature system or visually immature system. So due to any reason, if the binocular single vision gets hampered in a visually mature system. So what do we mean by mature? Any person who is beyond 9 to 10 years of age, then if the binocular single vision gets hampered, then it may cause by retinal rivalry, confusion, or diplopia. So what is confusion or diplopia? That means due to some reason, if my eyes are seeing two different objects simultaneously projected on the fovea only. So in confusion, both the eyes are seeing two different objects. But in diplopia, one single object is being projected on two non-foveal elements. So one fovea and one non-fovea. To make things simple, that's why I have put this O and I in capital letter in this slide. So confusion, O-C-O. There are two objects in confusion, but both are going on the fovea. So there is overlap of those two objects, which causes confusion on the brain. Diplopia, I have put I in red color. That means two images. Object is single, but the image is being projected on two different points of retina. Hence, you are seeing two images over here. So it's two objects or two image. Confusion is O, two objects. Diplopia is image and two I. So that's why diplopia I, confusion O. So the sensory this confusion and diplopia happens in case of adults. So if due to some reason there is no binocular single vision, or it gets disrupted in case of adults, they will start having confusion and diplopia. But due to some reason, if the binocular single vision gets hampered in child, that is even before the visual maturity happened, then here instead of confusion and diplopia, you will have suppression. So what is suppression? So suppression is basically one eye. So now this eye ends up seeing some object, this eye ends up being some object. So instead, to prevent this confusion or diplopia, my brain shuts down one eye. It's nothing but your amblyopias. So that is suppression. So suppression is central inhibition of confusing images. So suppression can be the shutting down. Suppression, if patient is having confusion, suppression of the fovea happens, and that is known as central suppression. If the patient is having diplopia, suppression of the extrafoveal element happens, and that is known as peripheral suppression. So two types of suppressions are there. One is central suppression, one is peripheral suppression. Central suppression is suppressing the fovea, that is in confusion. Peripheral suppression is suppression of non-foveal point on the retina, that is in diplopia. But remember, our brain is not a perfect structure. Sometimes we may end up having both confusion and diplopia. So if there is a confusion and diplopia which happens together, then sometimes the suppression of the fovea, suppression of the extrafoveal element, all these scotomas may fuse and form a one large scotoma in the eye, causing a dense amblyopia. So this is suppression, what we were talking about. So what did we learn till now? So till now we learned that binocular single vision is both our eyes fuse to see each other. If due to some reason like squint, cataract, childhood cataract, squint, or anisometropia, or any reason, if the binocular single vision gets disrupted, if it is disrupted in the elderly age group, patients will have confusion and diplopia because that is a visually mature system. But if that disruption happens in a baby, which is visually immature system, they will have suppression. That's why amblyopia happens in children. Amblyopia doesn't happen in case of adults because our brain is wired in such a way. To have a binocular single vision, clear visual pathway, no strabismus, and you should have a good fusion. Fusion can be motor, that is both the eyes acting together. Fusion can be sensory. After eyes act together, the brain has to act together, and finally we get a stereopsis. So this is the summary of what we learned till now. Then there are grades of single vision. So what is the grades of binocular? The name is important. It's Worth's grade of binocular single vision. So in case of the first grade of binocular single vision is basically simultaneous macular perception. So here two different structures. I have shown the example. There is a cage and a bird. So cage is different, bird is different. Two different structures are being fused to provide one single image. That is first grade. Now two similar structures which is incomplete when they get fused, and that is fusion. Finally, it goes into stereopsis. So the three grades of binocular single vision is simultaneous macular perception, fusion, and stereopsis. So with this, we wrap up the concepts of binocular single vision. So now that we learned all the grades of binocular single vision and the adaptations, if you want to test binocular single vision in any child, then you have to test all these factors: simultaneous macular perception, fusion, stereopsis. And if the binocular single vision is disrupted, then you will end up checking the abnormal retinal correspondence and suppression. So these are the aspects which has to be checked in any patient in whom we are checking for binocular single vision. So what are the tests? So if you want to test the retinal correspondence, there are two principles. One is known as foveo-foveal test, where you check the relationship between the fovea of the right eye and the fovea of the left eye. The tests which are involved are after image test and the foveo-foveal test of Kappers. The second principle is foveo-parafoveal test. That is, you test the fovea of one eye with the extrafoveal element of the other eye. The tests here are Worth 4-dot test, Bagolini striated glass test, and the red filter test. So these are the few tests to check for retinal correspondence. If you want to check suppression, you should know all these tests by heart. You should know which test is used for what. So they may just ask you tests for fusion. they may just ask you test for suppression. So if they ask a test for fusion, there is no point in writing all the tests of binocular single vision. You will just write those specific tests which are used to assess the fusion. That's why I have made a list separately for the tests of all the tests which are used for binocular single vision. I've segregated them. So these are few tests which are used to check abnormal retinal correspondence. These are few tests which are used to say suppression. So what are they? Worth-4 dot test, 4-diopter base out prism test, synoptophore, red filter test, Bagolini striated glass test, and the Fred test. So these are few tests which are being used to study the suppression. And when you want to study fusion, you will use the Worth-4 dot test, Bagolini striated glass test, and the synoptophore. So these are the tests which are used to assess fusion. Test for stereopsis, there are two different type of tests: qualitative test, quantitative test. So in qualitative, you have Lang's 2-pencil test and synoptophore. In quantitative test, all the tests which we use in our OPD, the TNO, Titmus fly, Frisbee test, random dot test, all these come under the quantitative, because we can exactly write 200 seconds of an arc, 40 seconds of an arc. So we can quantify the amount of stereopsis. So that's why these are known as the quantitative tests. So before you do any test for that matter, in case of binocular single vision, first you have to assess the vision. You have to do a proper refractive correction, give a good vision to the patient, and only then we would be going ahead with the tests. So let's go into each test. I think for the next 15 minutes, I would cover few of the tests. I may not be able to cover all the tests, but few important tests which have been asked in the exam. So the first one is the Worth-4 dot test. So we all know that in case of the Worth-4 dot test, it is done both for distance and for near. So this left one is what explains the Worth-4 dot test. You put a red color glass over the right eye, it's R and R. Green color glass over the left eye, and the patient sees 4 lights, 2 green, 1 red, 1 white. So normal patient, how should he perceive? He will tell that there is 1 red, 2 green, and 1 pink. But if the patient has suppression, now we spoke about this already. So what is suppression? One eye is not working. So if he has right suppression, that means red is not being seen. So he will see 3 green light. If he has left suppression, then that means green is not being seen and he will see 2 red light. In case of diplopia, it's the opposites of suppression. So he will see more lights. He would be seeing 2 red and 3 green lights. That's the 5 lights. Now, depending whether he is having a cross diplopia or uncrossed diplopia, if it is crossed, that means the red dots will be seen on the left side, the green dots will be seen on the right side. If it's uncrossed diplopia, then the red dot, that means it is straight, the red dots on the right side, green dots on the left side. So what is crossed and uncrossed diplopia? Remember that if your eyes are crossed, diplopia is uncrossed. So esotropia, your eyes are crossed, your diplopia is uncrossed. Exotropia, eyes are not crossed, your diplopia is crossed. So this is how you remember the case of diplopias. So the most important one of the use, and which is being asked very commonly in case of your Viva VOC, is the usage of Worth-4 dot test in monofixation syndrome. So in case of monofixation syndrome, when they see distance Worth-4 dot test, they would see 3 green light. That is, there is a suppression in case of distance. But when they see near, they will see normal. Because when the patient tries to see near, he will overcome the central suppression scotoma. So he will end up seeing 4 dots. But when he sees distance, he ends up seeing through the central suppression scotoma. So whichever eye there is a monofixation syndrome, microtropia with suppression scotoma, that eye he will not see any light. So here there is a suppression of the right eye. So he is seeing only the left eye. So this is a difference. Otherwise, rest all places the same interpretation may happen for distance and near, except in case of microtropia or monofixation syndrome. So this is a highly dissociative test. Remember this in case of Worth-4 dot test. The next is Bagolini's glasses. So in case of Bagolini's glasses, it is more physiological. comparatively less dissociating. So I have already put the glass photo here. This is the Bagolini's glass. So this something look like a round Gandhi Chacha glasses, and you have two glasses which have these striations on this. These striations are basically cylindrical glasses which are placed at 45° in one eye and 135° in case of other eye. So these are what acts as a dissociating factor in case of Bagolini's striated test. So you make the patient wear those Bagolini's glasses and ask him to see a point source of light. Now, because of those striations, the point source of light gets dissociated into striated lights. So if there is a normal retinal correspondence or a harmonious abnormal retinal correspondence, in those situations, you will see a cross, the normal cross of the right eye and the cross of the left eye. If there is suppression, then you won't end up seeing the cross of that eye. Either there is a right suppression or the left suppression. You won't see this or you won't see this. If there is a suppression scotoma, then in that situation, you will see a center break. In whichever eye you have the scotoma, that eye, the striation will have a center break, and here there is a right central suppression scotoma. So this is your Bagolini's test. So if you compare, most of the places have got both Bagolini's and Worth-4 dot test. So if you compare Bagolini's and the Worth-4 dot test, Bagolini's dissociates less than that of the Worth-4 dot test. I already told you it's more physiological, less dissociating, and we can see when you're using a Bagolini's glasses rather than red-green glasses, we can see through the Bagolini's glasses and judge what is the position of the eye, and you can give a prism and try correcting it and seeing what exactly is the response. And it's already been used. Some places it can be used to measure the amount of cyclotropia also. So this is Bagolini's versus the Worth-4 dot test. The next would be the red filter test. So in cases of red filter test, you basically place a red filter in front of one eye. So normally, this test is actually very subjective and it requires a lot of patient cooperation. So whenever there is a manifest squint, so you basically place a red filter in front of the apparently fixating eye most of the time. So you place the red filter, which can either be just a red glasses or place the red lens, which has been available in our own trial set. We place it in front of the patient's eye and then you see what is the response. So you project the light in front of them. So through one eye, he would be seeing the red light. Through one eye, he would be seeing the white light. And now, what does the patient perceive it as, both the eyes together, is how we interpret a case of the red filter test. So in case of this is how it's been projected. So in case of the esotropia, there is a uncrossed diplopia. So he will tell both the red as well as the white light, but he will tell that the red is on the right and the white is on the left. But in case of exotropia, there would be a cross diplopia. So the red would be on the left side, white would be on the right side. And in case of abnormal retinal correspondence, there would be slight vertical by placing the prism. So this is how you would interpret a case of the red filter test. So when we talk the next about the suppression test, the most important test which is being used is the 4-diopter base out prism test. So that's mainly used in case of the microtropia or in case of monofixation syndrome. And this test, it's quite tough to explain orally when how do we perform a microtropia 4-diopter base out prism test. So I have actually placed this video here. So what happens in case of a normal person is, so when you place, see this, when you place a 4-diopter base out prism in front of the eye, normal eye. So normally what happens, your eye tends to move towards the apex of the prism. So here I have placed a 4-diopter base out prism test in front of the right eye. So the right eye moves nasally because of the Hering's law. The left eye will move temporally. Now the left eye will start having a diplopia. So what happens? The left eye will now make a corrective movement and will move in. So this is a normal movement which happens in case whenever you place a 4-diopter base out prism. So if you place a 4-diopter base out prism, the eye will move towards the apex. The opposite eye will also move simultaneously. Then the opposite eye will move in to make a corrective movement to prevent themselves from the diplopia. So now let us see the next scenario. So this normal case means there is no foveal suppression in case of both the eyes. So now let us see the second scenario. We place the prism in front. There is a movement in both the eyes, but the left eye refuses to come back inside. There is no refixation movement, indicating that the left eye has got a central suppression scotoma. Patient couldn't appreciate the diplopia in the left eye. So there was no refixation movement which happened in the left eye. So there is a left monofixation syndrome, left microtropia with a central suppression scotoma. Okay, now assume that you place the prism and there is no movement at all. So this means that there is a microtropia with a central suppression scotoma in the eye in which you have placed the prism, that is the right eye. So this is your 4-diopter base out prism test. So once the 4-diopter base out prism test is done, the next one would be after image test. So after image test is very highly dissociating test. So each fovea you stimulate with the vertical or the horizontal bright light. So depending on the type of the deviation which you are having, so you will use that type of the stimulation to be used. For example, if you have got a horizontal squint, you use a horizontal beam of light to stimulate. If you have a vertical squint, you use a vertical beam of light to stimulate. And when you stimulate the two eyes, then after some time, you ask the patient what type of after image he's seeing from both the eyes. You check both in the dark room and the bright room to check for both positive as well as the negative after image. So depending on where the image is present, so like the left eye and the right eye, you can see here I've already drawn. So if there is an overlap, that is a press, cross mark, normal retinal correspondence, abnormal retinal correspondence, there will be some amount of deviation, and there is the suppression, you will actually see only one horizontal or one vertical line. The patient says that in the other eye, he couldn't appreciate the after image, negative after image. So that is basically the after image test. So with this, we wrap up all the tests of abnormal retinal correspondence. We wrap up the tests of suppression. So now the last set of tests which we would be studying today would be the test for stereoacuity. So in case of stereoacuity, we already told that there is qualitative and the quantitative test. The most commonly performed quantitative test in most of the places, the most famous one is the Titmus fly test. So if you can see here, there is a fly on one side. So in case of the fly, it's basically that you have to hold the child. It's basically used in case of children. It's mainly used to assess a gross stereopsis by about 3,000 seconds of an arc. So you ask the patient to just hold the two wings of the fly. If he's just holding it on the plate, then that means the stereoacuity is comparatively less. The other part of the Titmus fly test basically has got circles. So there are 4 circles which are present in each diamond. Of the 4 circles, one circle appears to be elevated, and you have to ask which of these circle is elevated in each of them. So there it ranges from 800 seconds to 40 seconds of an arc. The below one is the animals. So you will ask in a row which animal appears to be elevated, and based on that, we grade them from 400 to 100 seconds of an arc. This is based on linear polarization. So for Titmus fly test, you would use a polarization glasses. So polarized glasses. The next one would be TNO test. Here, instead of polarized glasses, you use red-green glasses. So the dissociating factor which is happening here is basically because of the red-green glasses, more accurate than the Titmus fly test. So there are basically 7 plates which are there here. The first 3 more or less tells about the gross stereopsis, and the others are used for quantification. So there are 480 to 15 seconds of an arc. Why did I say TNO test is more reliable than Titmus fly is? Titmus has some amount of monocular cues, but TNO test absolutely doesn't have any monocular cues. So most of our studies with respect to stereo and all is mostly done by using the TNO stereo test. The next is Lang test. Most of the time it's been used in case of children. There is Lang 1 and Lang 2. So the Lang 1 is what you see below. It has a cat. Lang 2 is what you see above. It has a moon. The star which is present here can be seen even by using monocular cues. So star is almost always present. You need to identify the rest of the symbols. Based on that, moon is 200 seconds, star is 200, car is 400, elephant is 600. So each of them have their own seconds of an arc, and it is seen alternatively by each eye. Because this Lang's test has got some cylindrical element which is embedded in it, and that gives disparity, you need not wear any glasses for this test. So this Lang test doesn't require any glasses, unlike Titmus, which need the Polaroid glasses, and the TNO test, which needed the red-green glasses. The next test is Frisbee glasses. It has got these 3 transparent plates, and on each transparent place, there are 4 squares. If you can see here, these 4 squares have got some arrows drawn on it. Out of these 4 square, 1 square has a circle which is embedded behind. So you have to find out which square has a circle. So if you finish the first square, which is 6 millimeter thick, you go to next square, which is 3 millimeter, then that last square, which is 1.5 millimeter. So totally you can range from 600 to 15 seconds of an arc. So after the Frisbee test, the Randot test, absolutely no monocular cues. So again, the same circles, the animals, and the various images which are being projected. Again, you use linear Polaroid glasses over here, and it ranges from 500 to 20 seconds of an arc. So some places like intermittent exotropia, all these tests which I had mentioned are basically the stereo tests for near. But in cases like intermittent XT, where the stereoacuity for distance get disrupted earlier than stereoacuity for near, in those situations, we also need some tests for assessing the stereoacuity for the distance, and this is one of it. So distance stereoacuity testing. And for those people who don't have any stereoacuity tests which are available, and if you want to still calculate the stereoacuity, this one test which has been published by Pradeep Sharma sir, the Lang's 2 pencil test, it can either be done vertically or horizontally. So horizontally is more preferred than that of the vertical. So examiner holds 1 pencil, and we ask the child to touch the tip of the other pencil by using this pencil. So this is a crude test for gross stereopsis, and threshold basically comes somewhere around 3000 to 5000 seconds of an arc. So with all these tests, I think in the current scenario, when before any government exam, before any government jobs, or in medical point of view, when we want to take some PG for ophthalmology, we realize so many residents join up ophthalmology without knowing that stereoacuity is a very important point for an ophthalmology surgery, and many people end up performing multiple PCRs because somewhere their stereoacuity has been compromised. So this is a world of binocular single vision. So now binocular single vision is no more an option. It has become a necessity. Every person is supposed to have a binocular single vision for their future well-being, for their future education, for their future job, and for their life. So I think binocular single vision is something which is confusing. Even we read it multiple times, yet get confused every time. So for postgraduates here, you need to know what is, if somebody asks in the exam, what is binocular single vision, 100% you have to mention retinal correspondence, Horopter, Panem fusional area. Mention this, draw that circle, draw the Horopter, and one here, one there, so that image which I had shown, and you have to mention all the tests. I think the tests are very well mentioned in every book. The word 4-dot test, Bagolini's test, after image test, stereoacuity is mandatory. So if you mention this much with the grades of binocular single vision, your answer will be 100% complete. So with this, I wrap up my today's topic on binocular single vision. Hope I'm not confused much. I know the topic is confusing. So now I open the discussion. So any doubts for anybody, we can go ahead with it.
Before we move on to the question, ma'am, first we'll have to definitely thank you for that wonderful explanation of all the different tests and the diagrammatic representation that you've shown. I think there's hardly anything left for the students to ask for.
Thank you. I think
Very nice lecture, Dipti.
thank you, sir.
Even if I am a corneal surgeon, no, since I was compelled to see your entire PPT, I thought there is something to learn from this class.
Thank you, really thank you. But I think this is been asked repeatedly. I went through with the question papers again and again, every alternate or 2 to 3 years once BSV is being asked, either as a complete question or they ask only Horopter, they ask only diplopia, confusion. So it's been asked again and again. So that is the reason why I thought let us make it more understanding for the postgraduates as it's asked.
Apart from theory, at RP Center in our exams, a long case of squint is a must for students.
Yes.
And they are universally asked this question: what is stereopsis, grade of stereopsis, how to test? That's a very favorite question, especially with senior professors.
True. So I think it becomes mandatory for postgraduates to know all these things now.
Yes. So Pranita, Gunjan, any questions there? It's a very difficult topic.
Yeah.
Students will be confused what to ask.
The PPT
Then to go and revise.
Thank you so much, Dr. Deepti. I must say it was very well explained, very nicely explained.
Thank you.
I have 2-3 questions from postgraduate students.
Okay.
First is, why is sensory evaluation of binocular vision important before planning for the squint surgery?
Okay.
So why it is important? Like we should do the test and we should know about it. Yes.
So the sensory evaluation, see, motor evaluation just tells me that there is a squint. I have an esotropia, I have an exotropia. But how is it affecting my vision? How is it affecting the visual function? We think vision is basically just visual acuity. No, vision is visual acuity, color vision, contrast sensitivity, hyperacuity, and stereoacuity. So all these together puts up into the vision of a child. So now if I take a case of intermittent exotropia, this child is just intermittently squinting. So parents tell me, madam, दिन में आधा टाइम करता है, आधा टाइम नहीं करता है, क्यों ऑपरेशन करना है? Now this you can prove when you do a stereo test to them and you put a polaroid glasses on the child as well as the parent. The parent will say, हाँ ये सर्कल उठा हुआ है, बच्चा says नहीं दिख रहा है. So then you can actually show the parent कि जो क्या चीज अफेक्ट हो रहा है इस स्क्विंट से. So many times it's the sensory part which actually tells us what is the type of the modality of treatment which we should be using in this patient, when should we wait, when should we actually go ahead with the management or the surgical aspect. And so many times it tells us if our surgery is actually working or not with the prism. When I give a prism adaptation to a patient after maybe before squint surgery and the patient complains of diplopia to me, I know that okay, so this patient is going to have a diplopia and this is his sensory status, what he's going to have after the surgery. So the sensory status is what is making us to do the surgery. Motor is the cosmetic part what we are correcting by doing the surgery. So the gift of functional vision what we are giving is basically the sensory part.
Yes, and most importantly, in IDS patient, it is the most important deciding factor to see the stereoacuity, and that only is the most convincing factor, as you already explained to the parents, because otherwise they don't know the importance when to go for the surgery.
True.
One more question. How do monocular cues compensate when binocular vision is absent? So what are the monocular cues, how it functions, like what are the tests, like how do it compensates? Yes.
So monocular cues may exist even with a binocular single vision patient also. We all have some amount of monocular cues. So when we see a photo of maybe a leaf and a dewdrop over it, so we can see that dewdrop is round spherical on the leaf. We see it in the photo. Even though the photo is 2D, we are still appreciating a 3D version of the dewdrop, basically because of the monocular cues which is being present in that image. So monocular cues is in those patients who have or who don't have binocular single vision, they still appreciate some amount of 3D because of the color, the size, the disparity between the images of the, like if you give a photo to me of a boat which is in front of the bridge. So I would still know that this boat is in front of the bridge, even though I'm not seeing a 3D image, because of the distance disparity which is being shown in the photo, the texture. So all these, some 2D factors which are present, size, shape, color, texture, all these still give some amount of the information about the stereoacuity or some amount of 3D vision to us. And this is basically the monocular cues which works in people despite having one-eyed, being one-eyed, who are still, there are so many people who are doing so many 3D activities despite being one-eyed, and that these are being compensated by all these factors of monocular cues.
Yes, and accurate stereoacuity test, they already compensates for those monocular cues to give us the accurate findings of the binocularity.
True.
Yes. One last question, though there were no questions as such many, but one is, in which cases is it worth attempting to restore binocular vision in adults with long-standing strabismus?
See, when you say long-standing strabismus, is it a long-standing from childhood? In that situation, the patient will be having a real dense amblyopia. Can I restore a binocular single vision in him? Maybe no.
Maybe no.
So it depends. What do you mean by the long standing? There are so many acquired congenital palsies, congenital superior oblique palsies we get from maybe from 2 years. So if you consider that as a long standing, believe me, it's really tough for them to neuro-adapt themselves in that age. Despite us making the eye perfectly straight, they still end up having so much of rivalry, and they keep on telling the diplopia part. So this restoring binocular single vision in a squint, I think it depends. So most of the time, I think it's the intermittent squints which we successfully end up restoring the binocular single vision. But in most of the places, we are attempting to restore, but a very long standing, if you're talking about a dense suppression with the obligatory suppression and an amblyopia, it may not be really possible.
Thank you so much for explaining it very nicely. I don't think so there is any doubt. And for PG, definitely this much is enough, more than enough to attempt, or for even Viva, you have explained so nicely that they would be able to answer. Yeah. Thank you so
Thank
much.
you. Thank you. Thanks a lot.
I think with that,
yeah.
yes, I think with that we have come to a conclusion of this class. Thank you so much, ma'am, for taking your valuable time and preparing that wonderful presentation. And we're looking out to you for the handout as well for this class that can be shared to the students.
Yes,
So any
I'll
comments
send over the PPT, and I think that can be given to postgraduates. If they have any doubt, I'm always available. I think because in some of my slides, I've not written anything much. I was drawing and explaining, because even I tried to understand so many things before explaining you people. So some of them are videos. In some, there is no written material, just images. So any doubt with respect to the printout or handouts, you can anytime reach me out. That is not a problem at all.
That will be great, Dipti.
Thank you.
It's a difficult topic.
Thank you. Thank you, sir.
Thank you so much. And I think let's conclude for today, Prism.
Yes, sir.
Thank you.
Thank you, Dipti. Thank you, everyone. Thank you, Sunil.
Thank you. Thank you, sir. Thank you, ma'am. Thank you.